All right. Thank you, everyone, and welcome to the CITRIS Distinguished Lecture Series. As you know, this is a relatively infrequent occurrence for us, but we try to do it as often as we can, as often as our distinguished members come to Berkeley. My name is Ravi Namana. I run the Healthcare and Services Initiatives here. And I should also add that we should welcome our web viewers who are at Santa Cruz, Davis, the Medical Center at Davis, and at UC Merced. So this webcast will be viewed by all these parties, and we'll also archive it on YouTube as we do now with most of our offerings. I have the distinct pleasure of welcoming a good friend of mine, Jennie Chin Hansen, who is now the President Elect of AARP, but probably only until, the next few days, when she'll officially be President of AARP. In 2005, Jennie retired as the Executive Director of OnLock, a group with which she was involved for over 25 years. And this sort of set the standard, or I should say the bar, high for community-based services to seniors. Today, she is also the Senior Fellow at the University of California, San Francisco, across the Bay for the Center for Health Professions, and a part-time nursing faculty member and a nurse by training. She also has numerous awards, including the 2005 Centers for Medicaid and Medicare, Centers for Medicare and Medicaid Administrators Award, the 2002 Gerontological Society of America Maxwell Pollock Award for Productive Aging, and the Women's Healthcare Executive Women of the Year for Northern California. She also sits on the Medicare Payment Advisory Commission, or also known as MedPAC. So please welcome our distinguished guest, Jennie Chin Hansen, to the CITRIS Distinguished Lecture Series.
Thank you, Ravi. I am absolutely delighted to be here. I have had this opportunity to be here on campus since about 10 o'clock this morning, and had a chance to meet actually some of you in the audience who are doing such seminal work relative to what CITRIS is offering here. I have really a great delight, as Ravi has said, that I've known him from the days that he was the Chief Information Officer for Health Tech over on the other side of the Bay, really looking ahead to what kinds of things are going to be helpful for the whole field of just healthcare delivery systems that make sense for the future. Now that he's localized over here and looking at the marriage between technology and how does that make a big difference for society. That's something that I'm excited about, to have a chance to explore some possibilities relative to a large consumer organization such as AARP. I get a sense that some of you in the audience might be AARP members, so I hope that you'll enjoy the fact that we are looking at ways that we too can serve society and think about effective relationships that will have a chance to make systems and care as well as technology usable to the large population. So what I wanted to have a chance to do is just point out, even as we know it and even what I heard today, that technology already is making such a big difference in people's current lives, let alone what we'll talk about going for the future. One of my colleagues at AARP has a daughter who has a heart condition, and the fact that she wears a monitoring device right now that transmits information back to her physician allows her a normal life. And in addition to the fact that this kind of information is transmitted to her parents, and the fact that then as a result her parents have a peace of mind that she can really participate in regular activities. In fact, she rides horses competitively. So the ability to be a part of regular living is something that is so enabled by some of the technological advances that occur today. So one of the things that we do know, and we study people who are 50 and older because that's our membership. This is what AARP now is comprised of. It may be a surprise to people to realize that we are now a member organization of nearly 40 million people. So outside of the Catholic Church, we are probably the largest membership organization in the country. The thing that we have a chance to do is to see that the way the organization first came about has such interesting synergy of how the future will I think, occur for AARP. We have multiple entities in AARP, and I'll have a chance to explain that because I think it will make a difference as to how organizations will interface with us. Because in fact, I met one of my colleagues here in the audience about what kinds of products might be helpful for the future. So people wonder, gee, is AARP an advocacy organization? Is it an educational organization? Does it help vulnerable populations? Does it help move the marketplace? It actually does all of these things, but through different entities. So what I hope to do in the minutes that I'll have a chance to talk before I entertain questions is to give you a sense of AARP as it is today and some of the areas that we know that work is being done, I think both nationally, but certainly acknowledge the work that's being done here at CITRIS, to see how we can think of the possibility of using the strength of our membership and the needs of our membership to make sure that we bring to the country, if not internationally, since we have international work as well, systems and processes and products and services that will make a difference in terms of society at large, and especially in areas that our members are particularly concerned about relative to their health care and relative to their economic situation. What I wanted to just describe to you really briefly, that when we have AARP, AARP is comprised of multiple entities. It still has the brand of AARP, and people oftentimes will say, when they see us write AARP, they'll actually expand AARP to the words, the American Association of Retired Persons. And I remind people right now that actually AARP is just AARP, because of the 40 million members, about half of us are still working or actually working part-time. So that part has changed. And we're not all retired by virtue of my example there, but of the 40 million of us, about 1/3 of us are under 60 years of age, another third of us are between 60 and 70, and another third of us are 70 and beyond. So we actually have the equivalent oftentimes of 3 generations of people who are our members. So for those of you who are members and get your magazine, I should share with you, there are actually 3 versions of that magazine. There's the front cover, which is the same, and I would say probably about 70% of the articles are the same there. But then we customize it, because there are many people between 50 and 60 who are still raising children, if not teenagers, and then people who might be older to really take a look at some of the kind of issues and tools that might be more useful to somebody who is no longer working and having different kinds of needs. So in order to meet the needs of 40 million people, you can imagine one size does not fit all, which is again a real comment about some of the technology that we'll have in the future. We do have a subsidiary that is relative to our commercial services. You'll probably have seen this in the course of some of the ads that are there. We do brand our name and try to move the marketplace. And a good example is when we do arrangements with healthcare companies or services that may be related to transportation or so forth, we try to set it so that the metrics that we expect really are about positively changing the marketplace. A good example, health plans in the past have not really necessarily focused on prevention as much as doing some other kinds of things relative to paying for medical care. We make sure that part of our metrics built into it is about prevention. Or if the fact that we do know from the Institute of Medicine studies or some other studies that come from the Center for Disease Control, that there is insufficient components of looking at populations as they vary. You probably see in the news health disparities are still seen to be quite significant, even in Medicare. So even though people have Medicare coverage, there are major disparities for this. So we built in some metrics to some of the kinds of performance relationships that we have with our companies that we do business with, so that we're really trying to be positive in the marketplace. The whole aspect of our foundation, which is a 501c3 designate. What that really just means is this is a foundation that does charitable work for the greater public. So it doesn't mean you have to even be a member of AARP. Examples of what we do there is even during tax time. We have 36,000 volunteers that help people do their taxes for free. And you don't even have to be a member. You don't have to be actually even as 50 years old. But if you find yourself needing financial help in order to file your taxes, we do that. And one that's quite amazing that we're able to do is have a chance to return back and find, help people find refunds that they wouldn't have been qualified for. So last year we did about, this last year we did about 2 million tax returns for people and help people recoup $150 million in terms of benefits. So that's kind of our charitable side for doing it. Probably the side that you know the most about is that of our advocacy side. The education materials that we provide, the advocacy for the certain kinds of issues and policies that arise, that's where we definitely are probably most known for and where the bulk of our activity is seen to be. And then finally, we have developed a global federation as well. We now have global partners. In a particular new entity called the Global Aging Network. And this is a federation of like-minded national organizations that include, at this point, Denmark, Italy, Canada, as areas that we have some similar kinds of interests. It's possible in the future when you travel you'll carry a global card and you can get discounts certainly when you travel as well. So this year we are pulling together our entire family of AARP, and that is, this is our 50th anniversary. And so some of you may be aware of that in our publications, that this is an opportunity for us to look back as well as look forward. So the whole role of technology is going to be something that I think is very, very key. One of the things that we have done, not so much from the technological side so far, but really take a look at unmet needs in the marketplace. Many of us who may have Medicare or coverage with our employer when we were working find that those are two very strong anchors of healthcare insurance coverage. But one of the areas that we did find was that people were not covered from the age of 50 to 64. And so often people do either lose their employment or not work as much. And what we were able to do is develop even an insurance a product that helped meet this particular need at a time that other insurance companies were not interested. Interestingly enough, too, when AARP first got started, it was started by a retired principal from California, the first female principal in the state of California, who found that when she was doing some volunteer work for her colleagues at the time, she found somebody who was somebody she taught with living in a chicken coop. And what had happened was the pensions at that time, which were in the 1940s about $45, were insufficient to cover both her health care costs as well as her basic food and medication needs. So the only thing she could afford was living in this chicken coop in the back of somebody's home. And she decided to really become active with that, and that's part of our activism history. But the interesting thing about developing a product for a marketplace that wasn't covering this at that time, and this is pre-Medicare, what was occurring at that time, if you were older, there were no insurance products available for people. And she went to 42 insurance companies before she found one that was willing to underwrite insurance for somebody who was older than 65 or older than 60. So we've always had this early connection. And, but part of it was to try to make sure that people did well. She started an organization for retired teachers from that episode, but because this product was so effective, and she started the first mail-order pharmacy because people couldn't afford some of the pharmaceuticals at that time, that people who were not teachers wanted the same thing. So that's why 50 years ago, AARP was actually started. So we, at this point, do have a philosophy, especially in our commercial side, to hit what we call the triple bottom line. So it's providing value to our members, making sure that we change social systems for the positive result for society, as well as to create a profit. And that profit is what fuels our ability to do some of our other advocacy as well as social change work. So with this, you know, now that we have this whole largeness of this, the partnerships that we're able to develop really hopefully do show that we influence the marketplace. We have 60 companies that we work with, from the National Association of Home Builders to Walgreens. And what we've done with the home builders is really work with them to look at setting some standards for what universal design should be in the future, so that people can really think about building homes as well as remodeling homes with this kind of impact in mind. We give out awards for this. The other thing we have done in terms of social impact is give awards to the 50 best companies to work for people 50 and older. So we are recognizing how important it is to have workplaces that take advantage of the skills that people may still have, but to knowing that there has been age discrimination, frankly, in many companies with people who are 45 and above. Our ability to recognize companies that are now at the forefront of doing this kind of employment that helps really start shaping the marketplace. So this is, you know, kind of the example of looking at what we can do with a large organization. Maybe more to point right now relative to CITRIS and looking at technology. We just finished a large survey and study of older people's willingness to use technology. It's a report that's out. It should be on our website. I just have still the last draft form. But it's about, you know, how willing are people to use technology to help their quality of living as well as safety in their home and communication. The long and the short of this is that with this study that was funded by the Blue Shield Foundation here in California, we do find that people who are older, and we're defining people older as 50 and above, and as well as the different segments of older population, are really quite interested in options for technology that will help them stay much more independent in their homes. The thing that people are worried about, though, is just the cost of it, as well as the ability to deal with the maintenance of it when things break down. I mean, this is the worry. It's one thing to buy something all working really well when you first get going, but then the whole question that comes up is, you know, how do you maintain that? So the average amount that people are seemingly willing to spend for technology is about $50 a month. So the whole question is, with all the technological kinds of things that are involved, you know, people will be willing to pay based on our survey, but at the same time, you know, it is a certain dollar range that people are willing to pay for. But on top of that, we still have to deal with the whole issue of how do you maintain this when they have needs that are higher. So the you know, the term that I will have a chance to be a part of is a 2-year term. And in this particular period, because as Ravi mentioned, I have a long healthcare background, as well as looking at how to help people understand healthcare and health policy. One of the things that we want to make sure to do is to involve our members as well as others as we address this whole issue of healthcare costs, healthcare quality, and healthcare access. There's a way that we as individual persons who are out in the community can really benefit from this. Our ability to make sure that there is collaboration, and this is something that AARP, I think, has evidenced itself in the past number of recent years, that there are partnerships more and more that we need to have. So it's not about just the insurance products. It's really about, you know, livable communities. We have, as an example, you know, developed a cadre of volunteers. All together, you know, we have what is equivalent to several million volunteers. Some of them are more active on just website, but other people who are actually doing things in the community. We actually have members now that are strategically planning to be on planning commissions, for example, throughout the country, so that the whole sense of safer walkways for people, some of the designs in their community are going to be much more appropriate for universal design, creating social systems. One of the things that we did recently was show, for example, as people are living out in suburban communities, they're not even walking places anymore. There are no sidewalks for people to walk to have a healthier lifestyle. So some of the design issues, some of the communities that are redesigning themselves, we have AARP volunteers, I think, effectively placed on different planning committees so that these voices of looking at what it means to not only be older, but to make a community a lot more receptive and vibrant for a healthier community is taking place. The thing that we recognize is that technology increasingly is playing a more prominent role. I gave you that one example of somebody who has a chance to live a much more independent life by monitoring afar. But we also know that the ability to pursue hobbies as well as social networking and connecting with games, be it themselves or with others. And right now we see that there's a real great bump of interest from grandparents to connect with grandchildren, not only through the usual cell phone and email, but even through our networking site that we have here. So what we do sense and understand as we work with others in this field is the necessary policy of high-speed broadband. We recognize that without this, we can't democratize, technology for everyone other than those people who can afford to pay personally. So right now, we are apparently one of the only industrialized countries without a national broadband policy. So you should know that AARP is working on this on the national level to really move a larger broadband policy that would affect the entire country and frankly, hopefully, bring us more up to speed, literally and figuratively, with the other industrialized countries. Emerging technologies in healthcare will certainly have a large impact in three areas. Delivery of care, which includes the needs of a physical building and the design, the way care is done across settings. I think many of us who may have been in a hospital ourselves or known of somebody who's gone to the hospital realize how fragmented care is. It's a very unsmooth, oftentimes, process when you go from the hospital to the home to some other setting or to a nursing facility for a while. Right now, it's very, very uneven, and some hospitals are able to do it better than others. But this is a universal problem right now in the country relative to this. And then finally, the third area for emergent technologies is looking at the workforce. Being a nurse, some of you already know that it's been covered quite broadly that the nursing shortage is quite significant. We predict in about 20 years there'll be a shortage of 800,000 nurses, and in particular just looking at the issues here. So are there different ways to look at technology that are about providing health care or having people monitor their own health care much more effectively so you don't need the people playing the roles that they currently play? So there's no question that we need faster ways and more effective ways, and I think CITRIS is here at Berkeley is in such a fantastic position along with its partner sites around the state to think about ways that we can expand and disseminate research much more rapidly so that it has applied impact for those of us who are managing our lives in the community, managing chronic diseases, or dealing with very severe illnesses such as managing our cancer at home. Health Tech, which is a colleague futurist site for health systems, has actually posed specific questions to help the technology debate come about. They ask what future care resident or home sites will look like. You know, will they be the hospitals as we know them today? Or, frankly, will we take advantage of some of the work that's happening in the military world, where the whole sense of hospitals and healthcare is done quite differently? They're under constraint situations in the battlefield, and they're developing ways of treating people that are quite different from what we tend to do as standard fare right now. And what will emerging technologies that have an impact on the layout? Some design aspects of hospitals right now is actually quite popular to look at. That's really appropriate. There are studies that show, you know, how many times, and I look at this especially with the Dr. Deming, who did the whole Toyota system that helped bring the whole industry ahead, that there are many industrial design kinds of things that current hospital structures add to great inefficiency, as you probably know, as well as lack of safety on the part of people. A DVD done fairly recently in DC that shows some of the best practice hospitals have actually physically redesigned their systems. And right across the bay in Alameda hospital system, not Alameda, the island, but Alameda hospital system, redesigned their emergency room in a way that doesn't have hours of waiting for people. If anything, they've been able to move people along, and so when you go into their emergency room on a Monday morning, what is absolutely amazing is that the emergency room is half empty, whereas most emergency rooms on a Monday morning are full of people waiting for services. There are ways now to use technology and design together to make sure workflow processes are much more effective and safer. And then finally, how will technologies interact with workforce, consumers, purchasers, and other people who are going to be influential in the future of aging care? I had a chance to see a demonstration here about things that are relating to people with Parkinson's disease, and just making sure that monitors are put on somebody so that we can begin to look at how they may walk and whether they're going to be at risk for falling. That's something that's quite different from some of the observational kinds of things that we currently use now as clinicians, but to be able to get clinical data. Some colleagues in the audience here are looking at how people can monitor their own clinical conditions. Some of you may know that diabetics currently can basically monitor themselves quite well with a glucometer so that they know how much insulin to take. Well, this kind of technology can move further on in other arenas that people can manage their care and get it appropriately done so. We were talking about people who go in for dialysis, which is a huge and growing area in the whole healthcare care side as well as the cost side. And the fact that people are routinely told, you know, you come in 3 times a week and you take these medications with this kind of frequency. But that's kind of like the broad brush. You know, that's like one way of treating with everybody. But not everybody necessarily needs it in that particular schedule, and they may not need their medications in the current schedule that is done. We don't really know that right now, but some of the work being done here on this campus can really titrate it so that you know whether or not it's time to go, that maybe you might be a person who only needs to go 2 times a week, or you might be, frankly, a person who would do better by going 4 times a week. But to have that kind of knowledge of you clinically is going to be something that will be able to be done as a result of technology. And it doesn't mean you have to traipse then necessarily into the doctor's office or into the clinic. This could be done clearly over the phone or on the internet. So there are going to be processes that are changing, and it really then helps people become much more able to have a quality of life as well as reduction possibly of cost as a result of this much more customized way of doing things. So right now already nearly we understand that by 4 years from now, nearly 3.5 million older Americans are already using network sensor devices for their health care. And so this is something that we find already here in this country. Separately, I had a chance to go to Japan, and one of the things I saw was this robotic seal that's the size of just a little larger than a football that was able to respond to human touch. And they have found that in some of the nursing homes for people who have dementia in Japan, there is a huge response to this kind of companionship that's there. So, you know, on the one hand, you kind of react to it that that's not the case, but this is so lifelike that it actually does receive this kind of receptivity. The other thing that many of you may have seen, that robots, some articles have come up recently, that robots could possibly fill jobs of 3.5 million people in Japan by 2025, and it could save Japan the equivalent of $21 billion as a result of their using this kind of system. I was in D.C. During a time that the Honda's Asimo, you know, this is something that we've seen, this robotic, and right now they're beginning to get deployed for use, for service for people. So the whole question is, who can benefit from this? Clearly all of us in this room, but AARP members are a group of members, obviously, that I'm going to be connected in a near and dear way with people, knowing that they can learn about these kinds of things. And I think AARP can bring this to both the awareness and the education and the visibility much more quickly. We do have a tremendous amount of data through AARP about just what the market preferences and the subgroups of people who are 50 and older. And being in touch with our members, not only through our website, but our publications, including our bilingual Spanish publication, Segunda Juventud, which has really great uptake in our Hispanic community. We have forums, our television programs that we're putting on, including working with PBS stations around the country. Right now we have a caregiving program that WGBH in Boston has taken on. The other thing that we want to mobilize our members and our volunteers through a Divided We Fail initiative, which I'll bring up in a little bit. Since you already know that the 50-plus population is far from any monolithic group, let alone the group that I mentioned as our members, one of the things that we wanted to make sure that, especially for those of us in California, are that much more aware of, there is so much more greater racial and ethnic diversity. Right now, from our demographic information that we know from the census, that since 1990, the overall Hispanic population has grown 60%. And Hispanics represent 15% of our total population, mainly living here in California or Texas. And by 2020, it's projected that 3 out of 5 people in our state will be Hispanic. So our ability, for example, as an organization to really be much more forward-looking to think about meeting needs of the Hispanic population, and then also how technology will fit in with this particular population relative to use not only here but globally. I'm going to talk for just a few minutes about you know, technology is something that I think a lot of us are extremely excited about, and when you're here at the university, this makes that much more sense. But there is a whole level of diversity that we as a society have to be aware of. We're not uniformly prosperous, and the fact that there are a great number of disparities that exist that are not only relative to racial ethnicity, but there is a huge poverty rate still in this country. With the advent of Social Security, when more than 30% of people were living constantly in poverty, that has reduced down to just over 10 or 11%. But you know, being poor in old age is still a great and frequent fear for people, mainly because 4 out of 10 people here in the United States will be poor at some time in his life after the age of 60. Women, minority, and people living alone are far more likely to be poor regardless of what their age is. Women's average Social Security benefit in 2006 was $806, about $244 less than men. So here women are living at a rate of about 6 years longer than men. Sorry about that, but it's just one of the factors of longer life. So on the one hand, you have longer life, but women themselves are actually quite afraid that they will live out their money. So it's especially important as we design all technology to understand this whole issue of both poverty and the fact that some groups, especially women, will live longer. And so what we will be able to do, too, is besides the kind of highlighting of companies that we do who focus on kind of supportive policies and programs for people who are 50 and older, what will be important to figure out is where technology will fit for an aging population who both wants and needs to work much longer. So there are other things. I think if people do make use of technology at home already, it's possible this telecommuting component that might be a possibility. Just as I think it was JetBlue who ended up using people who were housewives at home to become their schedulers, that people can begin to work from home. So there are other aspects of technology that may help people kind of continue their economic capacity. However, for people who are over 50 and in the top income quartile, it's quite different. They do have financial resources. They do spend trillions of dollars a year and have the largest market impact in terms of the dollars spent. The research at AARP also shows that those who are 45 and older account for all consumer spending. So that's quite amazing to see that this demographic spends this. Just alone, what happens is grandparents spend $30 billion on gifts and entertainment for their grandchildren. I bet you some of you are in this audience here able to do that. So putting the buying power that older people may have and the willingness to buy and try new products and services helps us begin to get a broader picture of an older consumer. Not all that different from younger consumers, but oftentimes with more both finances and leisure. On a whole nother event of thinking about technology, more life events, I think, as you know, occur between the ages of 50 and 65 than in any other time in a person's life. The typical boomer experiences about 2 major life events around career, family, finance, or health every year. So these kinds of life events definitely will affect the kind of behavior and attitudes that we have. So that's why we have definitely through AARP figured out that it's so important to segment individuals. So even though I talked to you about the larger segmentation of people 50 to 60 and 60 to 70 and beyond, you know, we have people now in all these segments who are newly married, possibly newly divorced, parenting, caregiving, and the question is, are they part of the worried well or dealing with already multiple chronic conditions? So there is a great deal of diversity for this population. One of the things that we also well realize that it's not effective to have this kind of monolithic approach. Right now, we do find that 80% of the boomers and 50% of their parents are actually online. And this is not just about email. It's just clear that people now, and I think how many of you have actually used the internet for making travel arrangements, paying the bills, or getting news? or gathering health information here. How many of you are already do that? Yeah. Well, this is something that already exists a great deal, and it is the fastest growing group coming online for the first time, and have been the older population. In 2007, we had a survey on internet use that we teamed up with Forrester US, and the greatest growth on using the technology has to do with shopping online and researching projects, electronically exchanging photos, entering sweepstakes is another one, and answering surveys. But what is most interesting is that there's a higher use among boomers than seniors, except for one exception, and that is playing games. Games are a major feature of why older people are online now. And so this whole delivery model for influencing healthcare, influencing prevention, I think will be one of the things that we certainly can do with games. And again, I had the real delight of testing out one of the games here on how to build up your trunk strength by standing on something and playing something on the computer. So it's playing, but it causes all your different muscles to keep moving, so that in fact you are strengthening your core strength, so that it helps build up the muscles to mitigate the likelihood for falls, which incidentally happen at a rate of 1 out of 3 people will fall in a given year who are 65 and older. You know, so falls for all of us. I have fallen. This is something that is just something that we don't think about as to what it is, and we tend to fall at home. So it really tells us technology at home will be a real important venue for some change. The whole thing that we can do with areas that make a big difference for people who have technology is looking at where people spend a lot of their time and efforts. And it's quite clear that medications are a big part of our life as older people. I think on average, the studies have shown that those of us 45 and older take at least about 3 or 4 medications, and it gets increasingly more the older we get. Medications become a big part of it, and so there are tools now technologically on how best to have automatic reminders that occur, and the whole aspect of how do we make that easier for people. So is there a way to make sure that that is going to be adopted much more? We are definitely trying to make sure too that as people face issues that are normal in aging, there's a degree of depression that happens for many people because their networks get smaller and they get isolated. There are some things being developed here that have to do with recognizing voice quality technologically as to whether or not people may be actually in a risk factor of depression. So it's amazing to realize that there's research going on right here in this building about using technology through phone quality when somebody talks to be able to discern that. The other thing that definitely has a chance to occur right now is this whole aspect of social networking. You know, many of you may have children and grandchildren who are real active on MySpace as well as Facebook. This whole thing on social networking has now moved over to those of us who are older. And they're finding that even though people don't physically get together, the ability to develop these social networks is real important. As we relaunched our website about 2 months ago at AARP, I don't know if you've had a chance to go on it recently, we do find that people are wanting to connect with other people. And actually one of the most popular social networking sites is about car repairs on our website. So it's there are different ways of communication and using technology today that weren't the same even a decade ago. So the evolution on this is extremely evolving. We know that boomers prize convenience and quality, and the fact that they're looking for other kind of experiences. So some people want, toys on the one hand. Others want to have tools to be able to make more effective decisions. People are then also looking for tools that will help them mitigate going to their doctors. I happen to be personally a member of Kaiser System, and Kaiser now has an internet site where I can communicate with my doctor and give him some symptoms, and he basically is able to give me advice and order some medications straight through that. Well, that has been tremendous in terms of saving the hospital my extra trip there, but it creates the kind of convenience that's real important. You know, one of the things that we found in this study that we did, that we just put out a couple of weeks ago, was that most people who are older would love to be able to do their pharmacology ordering much more effectively with their doctors. It's one of the biggest areas of looking at technopharmacy to be able to do this. And we're not talking just about ordering medications online, but it's the ability to make sure that you get some awareness and diagnosis of your pharmaceuticals much more effectively than now. The thing that has happened is there are other groups around the country, and there is a researcher by the name of Eric Dishman, who's the chair of this whole movement to get technology available for older people. So he says that his phrase is that we now need to have the consumer and the home-centric vision of healthcare. So this is a very different thing than always having it in hospitals, in doctors' offices, to be the center of care. And he says we've got to move beyond what's mainframe healthcare, which is kind of the big system healthcare, to the equivalent of the low-cost PC system of healthcare by getting it back into people's homes, where real-time prevention and detection can occur rather than going through your doctor's visit twice a year. So boomers want what we call AAA when it comes to technology. They want it available, they want it accessible, and they want it affordable. And clearly they want fewer cables. And with the wireless technology that is evolving and is much more common now, that is something that will help. Sensors and cameras that can detect misplaced objects as well as detect physical changes in ourselves. In addition, one of our sides of our organization, which is called the AARP services, this is the commercial side. We are now looking at other organizations that are developing products and looking at partnerships that we can help make sure that we vet these opportunities very carefully for our members, but that we will make sure that our members know about these opportunities to make sure that their life is better. We also look to shape Medicare in a way that they will pay for some of these technologies because of the research that will come about to make sure that these are cost savings as well as higher quality of life ways to use Medicare money. It's so much better to have something that's detecting something before it happens, making sure you get the right medication, making sure you get the right treatment, rather than getting kind of the generic big box way of being treated and then ending up in the hospital and having both our well-being of quality of life and suffering affected as compared to saving going to the hospital. And I think these are the kinds of things that are going to be possible by using technology and using the strength of AARP as an organization to help advocate for the kinds of evidence-based change that is very helpful. Right now, one of the things that we are emphasizing, I gave an example of falls, and correlating to this new study that we just did, that more than half of the people over 50 are interested in ways of making their homes safer. And so we're talking beyond putting in grab bars in our bathrooms and better lighting. But there are now sensors that are available for movement or if people are moving differently from the way they were moving before, that might be some indication that you are at greater risk for falls. And the fact that depression can be, as I said, monitored possibly from our cell phones. And these are the kinds of things that I think people are beginning to say, are there different ways to democratize and to normalize our living by using this kind of innovation and technology? One of the things that I also mentioned earlier is our partnering with the National Home Builders Association. What they are doing is beginning to work with communities around the country. Of mention is the Armory Park del Sol in Tucson, Arizona. The homes that are being designed in this particular development have universal design elements that have wide doorways, so that if we do need in the future some assistive device like wheelchairs, and the standard technology is just is standard and state of the art. Their homes are energy efficient, and they use solar and water heating systems that actually reduce energy consumption by more than 50%. So these are things that people are beginning to be really interested in as we, at the same time, I know that CITRIS is working on aspects of the environment. Are there ways that we can make lives have solutions that are a lot better for their well-being in terms of aging, but also be effective in terms of environmental concerns? Right now, also Blue Roof Technology in McKeesport, Pennsylvania promotes senior smart technology that all kinds of medical informatics are built into some of their assisted living facilities. So this is the wave of the future. I think we've seen this title called Smart Homes, but it will take a large public awareness campaign that AARP will be a part of, that this is not sci-fi. This really actually exists today. And moving on to a different part of this with technology is acknowledging that 40% of boomers right now are caregivers. There are actually 44 million of us who are caregiving in one form or the other right now in the country. And we are facing this caregiving crunch, which means we're sandwiched oftentimes between the need for dependent older friends and relatives, sometimes living far away, as well as our own dependent children. And family caregivers, in particular, are an audience right now who are willing to use new technologies like telepharmacy that I mentioned, as well as telemedicine, to help support their loved ones remain more independent in the community. In addition, there are almost 1.5 million grandparents who are the primary caregivers for their grandchildren. So the whole ability of staying in touch, as well as using resources through the internet, are something that are built into the addressing the stresses of caregiving. So what are we doing? You know, one is looking at the future of aging services and the use of technology. We've backed up a little bit, and some of you may have seen the ads on television, that in addition to talking about specifics about technology, there really is a much greater issue about the healthcare costs, as well as the healthcare, as well as the economic insecurity that people feel. And so since we've had gridlock for so long in our political process, we decided back in the beginning of 2007 to join up with forces that oftentimes aren't the ones that would get together. And so AARP spearheaded this effort called Divided We Fail, and it brings together the Business Roundtable. And the Business Roundtable is comprised of the 160 largest corporations in the United States, SEIU, which is the fastest growing union in the United States, and the National Federation for Independent Business. And this is you know, I think it's 2 million members of small businesses that operate throughout the United States. Now, this is not an easy cast of people to bring together because oftentimes our interests are quite different. But what we have agreed to are some principles relative to healthcare and relative to economic security to say, you know, we have a lot more in common here that we need to approach our elected officials about. So to date, you know, with this coalition, and we have about 80 organizations who've signed on, like the American Heart Association, the Cancer Society, to really say that we need our elected officials to do something very specific about this in this term. As much as we had such difficulty, say about 13 years ago, passing some kind of health care reform, I think because these different individual constituents now, from big business to small business to labor, really realize that everybody's got a stake at this, and we've got to figure out some way to get beyond the lobbying that we individually do for ourselves, but we've got to make sure that, you know, society is good not only for those of us who are already in an older capacity, but for our children and grandchildren. So this is what we are doing together. And then AARPs individually, as well as with some of them, are actually doing some specific advocacy and legislation. And the legislation we have supports a specific piece of legislation called the Falls Prevention Act. I mentioned to you how significant that is, but you know, on a given day, 44 people actually die from the falls that I mentioned. And falls affect older people much more acutely, so that $20 billion in direct medical costs are occurring. So basically anywhere from $20,000 to $30,000 out of pocket from individuals are as a result of falls, sometimes going to the nursing home. So this is something that we've joined on with about 30 organizations to make sure that we will promote. The Healthy Workforce Act would give incentives and tax breaks to employers to provide wellness activities and facilities to their employees. So basically we're trying to build a different culture in the workplace right now to make sure that people will do this. Recently, just actually about 3 weeks ago, we signed on to a bill right now that it's bipartisan called Caring for an Aging America Act of 2008. Caregivers, whether they're geriatricians, nurses, pharmacists, social workers, or aides, are going to be that much more important as a workforce that we're going to need to care for people who will have health conditions and long-term care needs. And this is the last one I'll mention here is called Wired for Healthcare Quality Act. Because this is so germane to this group here, we do know that health information technology has a lot of promise and has proven itself to improve patient safety, reduce costs, and cause actually a transformation of healthcare to make sure that it's far more in reach. We know that we could save dollars projected at $165 billion annually by implementing health IT and going paperless, that we are far from that. So it's really clear, as I mentioned earlier, that we invest in broadband so that it's available to everybody, including people who normally would not be served. So right now, I think that it's just an important time for us collectively to see that there's greater technological literacy that we can provide to our members and to others, and to make it much more accessible and affordable, because right now cost is still there. And there may be some programs that we really can engage for those of you who are able and interested to volunteer to help people who are not as comfortable with technology move into this world in a way that might be, we talked about earlier today, personal coaches for this, because it's one thing to have somebody come to your home, set up your computer, and leave. But it's a whole nother thing to feel comfortable to really know how to use your information and your computer, and so that you feel, you know, reasonably competent, and that you can really make use of it for the best use of your well-being. So these are some things that AARP, with all of its hundreds of thousands of volunteers that we have, you know, there are different efforts that we have really to directly serve the community. And as I said earlier, I think there's going to be a special challenge to tailor technology to women, to minorities, those with low income, and those with little education or have a different primary language. But I think that we are able to really see that in the horizon there are these kinds of opportunities. I think the opportunity for AARP have a chance to work with others, and especially with organizations here with the university system to make sure that people get the best of this technology in a way that's understandable and usable and relevant to their life. So I'd be happy to answer any questions that people might have about our thoughts toward technology or anything specific to AARP. Yes? Yes. Okay. Sure.
Thank you. I work with human-computer interaction issues, and I'm going to actually be giving a lecture next week on universal design in the College of Engineering. And one of the things that I'm not sure about is that it sounds like you were talking about universal design for applying for architecture, but a lot of the principles also carry over for engineering processes. I was going to suggest that because of the influence that AARP has, that it might start applying it to manufacturers. One of the things that I'm an advisor to some local hospitals, and one of the things that I'm finding out is that manufacturers aren't making stuff usable because the customers aren't asking for it. For example, does AARP in its technology acquisition process have standards specifying what kind of usability tests need to be used before they'll buy any technology? My impression is they don't have that.
Yeah, I probably, I'm not equipped to answer that right now, but we could, you know, I think your point's absolutely well taken, whether it's packaging of things, you know, design of items for people for better universal design.
It's also, for example, I was involved with evaluating televisions for the hospitals, and they were hard to use because of the way that they were designed.
Right.
But one of the consequences was that nurses were having to take time to go down to the patients to show them how to use the hospital, use the television. So that meant that they were losing hospital time.
Right, right. I think you're absolutely right. I think the ability to kind of think of this much more ecologically in terms of our ability to have this universality from all dimensions of this. So I think the home builders are probably kind of a logical first place to easily go to, but the principles that you're mentioning are far deeper, and I think it's something that's a point that I certainly would take back, because we have a consumer division of public policy, and the ability to have these kind of issues brought forth is something that would be definitely there. Thank you. Yeah.
Anybody else?
Early in your presentation, you mentioned that you'd done a survey and that the respondents said they'd be willing to spend $50 a month on technology. I wondered if you could provide a little color. I can think of a huge range of things that might be technology.
Right.
Some of them very close to healthcare, for which I'd probably spend a lot more than $50 a month.
Right.
Some of them like a broadband internet connection so I could play games, where maybe $50 a month would be more than I'd want to do. So do you have some insight into what people were thinking when they answered that question?
You know, I haven't had a chance to actually read the actual subs of the report relative to that. I think it was a generic financial dollar amount, but it could range from paying for service separate from kind of the healthcare technology piece, because of course those things would be much higher. But I think it's the general access side is covered in that $50 a month, because I think some of us now who are connected to using services pay well over $100, you know, for just access itself. So I think it leans more toward access. It is not as specific about devices as incorporating in. But the report is called Healthy at Home, is the title if you go to the AARP website. And it's something that you can download or wait until the hard copy comes out, because I don't even have a full hard copy yet. Yeah. Okay. Yes, hi.
Hi, Jenny, how are you?
Good, how are you?
I'm Susan Hoffman, the director of the Osher Lifelong Learning Institute here at Berkeley. And about a month ago, Dan Mogilov, who runs our public affairs for the university, made a presentation about where there was users of streaming video on the internet. And the fastest growing users of that were people over 50. And they were asked how they would like to use it, and they said for lifelong learning was one of the key responses. And I think that we really, while we've got online courses and curriculum, I think we're just really still at a kind of early stage, primitive stage, around how else we can make that much more dynamic. And so just to, I guess, to make that point and to let my colleagues know in the room that we would love to partner with folks in CITRIS or other parts of the university. Our program right now in our first year of relaunching has 600 people over 50 involved in courses from 1 course to 12 courses, you know, over the year. And they're very interested to learn more.
Excellent. Well, one thing I learned today is the fact that some of these previous lectures ended up being so are actually put on YouTube. And so the ability to use that and know what these lectures are about, that some people, I think some lectures had gotten like 10,000 hits because of just the nature of it. So it may well be is the ability to connect within the campus here, as you say, to make sure that your 600 members in particular, know of their availability. Yeah. Sometimes it takes meetings like this to kind of bring one's family back together as well too. But there's some tremendous resources that are here with the CITRIS program. Okay. Well, thank you very much for being here this afternoon, and certainly. For those of you who are AARP members, there's actually an email site that you can write me if there's some other comments that you have. And so just know that I hope in my 2-year term that I serve as president for the association is to bring some of these things on healthcare change, healthcare policy, much more to a regular grounded level. There are big things right now when we know as a country we're spending about just over 16% of our GNP on healthcare, whereas other developed countries are at most spending 11 or 12% and getting a lot more coverage for it. So we know we're spending a lot of money in the United States on it. So some people we have great coverage, but some, we know a lot of people who are uninsured. So my hope is to bring issues that are within the scope and sphere of your direct control, whether it's about medications, whether it's about fall prevention, and a third area that I haven't brought up, that just talking about what our wishes are and some of the conversations that we would want to have with our parents, our grandparents, relative to their life, relative to getting help at home, relative to specifying what our wishes might be, are conversations that oftentimes aren't held here in society. They say America is one of the few countries that thinks that passing on is an optional event. And so the fact that we have these conversations with our family members so that they know what to do, and I think some studies have come out even in USA Today, quoting Dartmouth work that has been done, that there's so much money oftentimes spent in the last 6 months of life that don't necessarily give the kind of quality, compassion, and value. So it's something that, an area that we may want to begin to take hold of with our family members. And it's not something that is easy to converse about. It's a lot easier to think about exercising so you don't fall. But at the same time, it's really a vital part of our life cycle of living. So I hope to, because I am a nurse by background, these are some things that I can help convey, that our ability to have a quality of life, spending the resources that are necessary, but making sure that we are mindful of our healthcare resources for our children and grandchildren. So just know that that's what I'll be working on in the next 2 years. Thank you.